Thank you, Jasper, and thank you to the rest of the delegates. And I hope this is going to be insightful. Uh, um, what happened last time was that we had or lost the share screen, and some of the stuff didn't come over. So I'll try and just to repeat some of the stuff at the end. But yeah, let's start for tonight. And whenever doctors talk, we normally try and confuse people by using big names, give fancy Latin names, and that way we sound very impressive. But at the end of the day, doctors are just normal human beings talking a different language. And I actually decided to continue with the basis that we laid last time of talking about a biopsychosocial model. And if you think about it, probably the number one symptom in medicine, in diseases, is pain. And I thought that we can actually just look at a few definitions and why and what pain is, but specifically more in chronic pain. Why do we struggle for the rest of our life with so-called chronic pain? So let's see how we can start and unpack this. So the first definition that I want to give is what the international definition that's laid down in the international media or scientific journals is it's an unpleasant sensory and emotional experience associated with an actual or potential tissue damage or described in terms of such a damage. Pain is always subjective. And just if you think about it here quickly, if you think about it, it's an unpleasant sensation, and it's always connected to an emotional experience. And pain doesn't have to be real. It's just how you interpret it. It can be actual or potential tissue damage. It doesn't have to be a real incident, but it's always, like we say, subjective to how the patient experience it or the person experience it. I'm just going to write. So I'm going to ask 3 questions, and I want you to answer this quickly for yourself. With what do you see? With what do you hear? And with what do you feel pain? Now, if your answers was that you see with your eyes, you hear with your ears, and you feel pain with your skin or nerves, then you're probably believing a lie. So we see with our brain, we hear with our brain, and we feel pain with our brains. Our eyes, ears, our skin or nerves is just receptors that interact with our environment. So the question that we need to ask is, what is the function of pain? Now, there's a zillion contributors to how anybody experience pain. And basically, if you think pain is a function of the brain, and I'll elaborate on that a bit later about the conscious brain and the subconscious brain or mind, why do we all react differently to different stimuli? For instance, some people are highly allergic to bee stings, and to others it makes nothing. The emotion of why do we blush? And why do some people blush and others not? If you look at the bottom left picture, what do you see? The perception. Some people might see a vision or a perception that things are going in or things are coming out. And also the emotions that, for instance, a red flag or dot can provoke, or that a blue color or green color can be a sign of or provoke a sign of calmness or peace. So all these things play a role in how we interpret the signals that we get from our environment. So if I can quickly just give a bit of a feedback, pain is basically, like we said, just a sensation coming from wherever the receptors is and trying to give a message to the brain, and the brain needs to interpret this message. Is this danger to me or is it safety to me? Now, just to give a bit of medical background, perhaps, and I'm not going to go into detail in these talks, but our brain starts with a spinal cord. We've got different lobes or areas in the brain, the temporal lobe, the frontal lobe, where most of our reasoning is happening, our parietal lobe, and our occipital lobe, where most of our visual, or the part of our brain with which we see, and then our cerebellum, which is basically our coordination and balance systems. But then on the other hand, we have all this emotions, arty type of people, or uh, people who are very artistic, the different music things. It's how we wired, if I can call it that. The scientists versus the arty people, or the left brainers versus the right brainers, whatever you want to call it. We all experience our environment differently with different emotions. But literally, if we do a cross-section through the brain, we have what we call a homunculus, or an area of our brain which is mapped, where we localize certain things. So for instance, the foot and the hip area, the trunk, the arms and the hands lie next to the facial areas, the tongue and the larynx. And this is where your brain can actually start acting like a GPS. Whenever it perceives or get a signal from the body via the spinal cord, it will map it in your brain so that you can localize from where this signal comes. And also start reasoning, is this danger to me or is it safety to me? So like I said, pain is a sensation and emotion created by the conscious brain in response to multiple stimuli which the brain perceives as threatening. So if if you have a dead body, he's definitely not going to experience the stimuli that you have if you cut the leg off or pinch the person or stick a needle in his body. It's the conscious brain that actually interprets these stimuli. So pain is a construct of the brain in response to a threat. And that response normally puts us into a fight and flight mode. And I'll talk about that a bit later. And so pain is not a measure of tissue damage, and pain does not equal harm. And just as an example, for instance, if you walk through the veld and a little branch nicks you and there's blood, will it affect you or will you feel anxious about it? Probably not, because it's just a little scratch and there's blood. But if you have a snake that bites you, you might see the two fangs of the snake, but there's normally not bleeding associated with it. And yet that will put us in a potentially life-threatening condition. And this is how the body or the mind needs to respond. Is this danger to me or is it safety to me? And a higher order, again, one of those big words, somatosensory construct, in response to the perceived threat. So if you think that the snake is not poisonous, then you will probably ignore it. But if you think it's poisonous and you're going to die from it, you will start going into a fight and flight mode. So chronic pain is not a very helpful or useful tool for us, but because it's basically how we interpret the signals that will tell us if we are in danger or not. And the question that we need to ask here is this life-threatening to me or is it something that I can ignore? Right. So our brain actually can be overprotective. For instance, if the snake bites you or you see the snake fangs, we don't know if it's a poisonous snake or not, and yet we will probably be overprotective and take precautions that give it the worst case scenario. If it's a poisonous snake, we need to react to it. On the other hand, a persistent event where there is no longer tissue damage, like for instance, if you've broken a leg and after 6 weeks or 12 weeks, your leg should be fixed or the broken bones should be healed, why do we still experience pain after a period like that? Or for instance, if you had an operation, you've had a scar, the scar is healed, but yet some people still experience tissue damage or pain. And then obviously the increased danger message that we receive from, for instance, if you sprain an ankle or a knee, that will try and warn you, go slow on me. There is a potential danger that you have injured me. All these things can basically, we can sum it up and say that sometimes the pain signals act like an alarm system, and this alarm system can become oversensitive or dysfunctional or both. And then we need to reset this alarm system. So basically, if I have to give a bit of medical background, how does the physiology of pain work, or the perception of pain work? Now, number one, if you put your hand on a hot plate and there's an injury, there will be a signal going down your hand up to your spinal cord, up into the brain, and then there it will be distributed to different parts of the brain, where the brain needs to decide, is this danger to me or is it safety to me? And then send a signal back which will tell your body, pull back your hand. Now the interesting stuff here is, if I can quickly just explain these terminology, there's a transduction. In other words, it's like an electric current running through your body. And we've got different wires, different types of wires that can send fast signals or slow signals. For instance, if there's a life-threatening condition, you want it fast into the brain, versus where somebody is, or the wind is just blowing or touching your hand, which can be a slow sensation. All right, there's modulation. In other words, we've got different ways of how the body reacts to these uh, impulses that come from the skin or wherever. There's a perception created in the brain. Is this danger to me or is it safety to me? We need to make a cognitive decision or just react, and that will respond how our behavior is to, or how we respond to that signal. I'm not going to go into much about this slide further, but just to quickly sum up, there's always a incident or a stimuli going through the nerve fibers into the spinal cord, up to the brain, where it gets distributed into that different areas. We can localize and then make a decision, is this danger to me or is it safety to me? Very oversimplified, but just to get the idea. Now, slide intrigues me a lot. And if you think about how the good Lord made us, this is amazing, of all the different receptors that we have for pain or signaling pain, and all the different neurotransmitters that is involved, different receptors that's involved in different stages of uh, sending signals from the peripheral area through into the spinal cord, into the brain area, how we interpret it and send it back. So it's a very complex system, and I'm not even sure if doctors always understand exactly what's happening here, the different types of cells that's involved in that mechanism. But amazing thing just to say, there is a lot of different receptors and neurotransmitters that's involved in conducting the signals to the brain and back to the muscles. But let's look at, unpack this chronic pain symptoms first. Pain is because your nerves, or your peripheral or central nerves, are firing, not because your back is broken. So for instance, if we stand up in the morning and we're stiff and we're experiencing back pain, or we did too much exercise yesterday and today our muscles are stiff, does that mean that or that pain, does that mean that we are in danger or that we are in trouble? Now, I just want to quickly re-emphasize this. There's a peripheral stimuli going into the spinal cord, then up to the brain. into the thalamus, which is one part of the brain. Our limbic system is our emotional part, and then the higher levels are cognitive function, where we can reason, is this danger to me or is it safety to me? Right. If pain is essentially a central nervous event, in other words, in the spinal cord and the brain, treatment must be targeted at what's happening in the brain. So just to think about it, whenever I show a red light to you and I say I'm going to burn you, does that mean that there's actually a physical stimuli that's going to damage you? Or is it an impulse that's going to the brain and where you can say, I'm not going to be scared, I can ignore it and just continue? So if we talk just quickly about the biopsychosocial model, biomedical is basically what happens in our body. The psychosocial thing is how we interpret this stimuli in our brain or the signals in our brain and how it influences our reactions to our environment. Now, if I can, we in medicine, we call this the red flags or different color flags. Let's start with the red flags. That's where you have serious life-threatening conditions. In other words, where there's an infection, a fracture, or cancers, for instance, you want to know about it. So I've just, this is serious signs of pathology. In other words, let's quickly just call it names. This Cauda-Equina syndrome is basically where there's pressure on your spinal nerves. Now, if you don't release that pressure on the spinal nerve or spinal cord, you might be paralyzed. A fracture or a cancer tumor is always something that we want to know about it. Can we treat it and try and prevent it or turn it around? All the different symptoms, for instance, of weight loss over a 3-month period, if there's a loss of bladder and bowel control or incontinence, a previous history of cancer, or this saddle anesthesia, what they call, is where there's a numbness in your buttock area. Those are all signals of potentially red flags that the body is trying to warn us of something dangerous. Orange flags is mostly psychiatric symptoms. We call it clinical depression or a personality disorder or schizophrenia. It's a condition where people might experience that they hear voices in their head. Again, this is a central nervous system disorder, if I may call it, on how we perceive our environments or interaction with our environments. The yellow flags is sometimes the thing that we normally need to stand still and look more specifically into it, because this is generated by our beliefs, how we judge our environment or the interaction with people around us, or in any case, let's maybe put it in a different way. If you believe a lie, nothing I can do can convince you to do things otherwise. For instance, fear is something that is normally, we call it false evidence appear real. But if you believe that that false evidence that you see is real, that's how you're going to start acting or believe in it. So again, if we talk about pain, if you believe that something is going to be painful, for instance, people having a phobia for a needle or an injection, which is not life-threatening, it will put you into a state of panic or even have phobias for it, where you don't want to go for an injection. So if we pull this through to the concept of pain, if you have a false belief around a stimuli that it can be life-threatening, obviously you will react accordingly and yeah, sometimes worsen your outcome purely because you react inappropriately to a stimuli which is not life-threatening. Again, your expectations of a poor outcome or poor treatment plan, if there's other reasons for delaying to return to work. We all know the story of getting a sick certificate so that you don't have to write a test. Our emotional responses, um, that the distress not meeting the criteria for a diagnosis of mental disorders. This is not like the previous one where we said the orange flags, but where we worry about circumstances or things around us, our fears, and where we become anxious and probably go more into a fight and flight mode rather than to rest and digest. Our pain behaviors, and this is including pain and coping strategies of how do we cope with pain. Um, so sometimes if we fear a certain stimuli, we will do activities to try and prevent it. Now, I mean, if you know you're going to break a leg, you surely don't want to do it. But if you need to go for a injection or go to the dentist, it's not life-threatening, and yet we sometimes postpone a consultation or try and duck and dive not to go for it. And this is all conditions that actually determines how we perceive or interpret a stimuli going to the brain. Right, blue flags is again the perceptions about the relationship between work and health. And this is sometimes things that we often see in people that want to have workman's compensation or want to be bored and so forth, that they believe that the work is too erroneous for them and that it will cause further injury. People who had a bad experience before or had a so-called slip disc or back injury are most of the time convinced that if they lift something heavy again, it will happen again and they will damage their backs, which is 9 out of 10 times not true. So if there is bad relationships at work, a bad supervisor or conflict with fellow colleagues, then these things can all contribute to how we perceive our pain signals. Just the black flags, uh, systems or contextual obstacles, legislation restrictions, options to return to work, conflict with insurance stuff, those things are all things that can influence people. Their injury might have healed, but if they go to work, they might lose their compensation, or if they go back to work, they will have to do the same physical work and not the light duty that they used to do or had while they had their disease or their injury. And this is all stuff that plays on to how we perceive or have pain. Now, I want to quickly look at this protectometer. Pain happens when your brain concludes that there is more danger than safety. Now, we called about these DIMS and SIMS, danger in me or safety in me. Now, you can look at all these things. The same things that can warn you that there's danger in you is also the same things that can say there's safety in me. So what's the difference between the danger in me and safety in me is purely how you interpret it. You interpret the signal or make a cognitive decision on is this danger to the body or safety to the body. Just a concept that I want to leave with you. How do our minds play up to us? Or how do we play up to this warning signals that our brain experience? Now, this slide is, I think I want to stand still with this. If you think about body, soul, and spirit, most of our battlefield is in the mind, where our thoughts, our emotions, and our will, or how we decide on our environment or to react to our environment, takes place. Now, our thoughts or thought process is normally influenced by our senses. Now, we all know about the sixth sense, but it's basically the feeling, seeing, hearing, smelling, and taste. And then woman has that sixth sense of they just know that there's something there. The intuition part of what I would like to call it. But our thoughts always triggers a feeling or an emotion. that will determine your attitude. Your attitude will determine a behavior, and the behavior will determine your results. Now think about it. Our thoughts can be positive or negative. And if we go through this process, depending on what our thoughts process are, will determine if our results are positive or negative. Now, all these thoughts are influenced through our community or society, the family, school, church, or university, work, marriage, other experiences are all coming through the senses that we have and program our thought process or our value system. Right, and remember this little guideline here, that our thoughts determines our feelings determine our attitude our behavior, and how we react to our environment. Remember, right at the beginning, I said that we use our eyes, ears, and skin just as receptors to interact with our environment. And it's a warning system to protect us, basically. But we need to interpret this: is there danger to me or is there safety to me? Right. Just an idea that I want to leave with you. As we have wrinkles on the outside of our bodies, we also have wrinkles on the inside of our body. So we all have a natural degenerative process happening in our body. But that doesn't mean to say that it is the cause of our pain or cause of a disease. For instance, disc degeneration, that's where the disc space just basically collapses over a period of time. At the age of 50, 80% of people will have disc degeneration. More than 50% at the age of 50 will have a disc height loss. So if you look at an X-ray, for instance, and you see all these things, doesn't really say anything unless you see it in the bigger picture, the context of how you interpret the X-ray. Does the patient have symptoms that can fit in with these so-called findings on an X-ray or an MRI scan? So again, when you go to the doctor, and the doctor make these comments, just ask yourself the question: is this the normal wrinkles on the inside of my body, or is this the cause of my pain or my symptom? So again, just to talk about different types of pain, as we talk in medicine about nociceptive pain, neuropathic pain, and then the combinations of these things. So nociceptive is one of those big words, which basically is nociception and pain are not equivalent, and there are no pain fibers, just nerves that send data to the brain for consideration. All pain is technically a brain-generated experience. However, the illusion that pain is in our body is meaningful and functional. So whenever you put your hand on a hot plate, the body needs to decide, is this danger to me or is it safety to me? And then it will localize it in your brain and say, pull away your hand, there is a possible painful or dangerous stimuli. Again, we talk about pain fibers or nerves. Our nerves are just an electric current, or sending signals from the peripheral area of our body to the central part of our brain. The neuropathic pain is basically where there's damage to a nerve. And again, if you cut a nerve off, theoretically, you won't feel anything on the distal part of the nerve. But if that that nerve is damaged, it can potentially start firing and sending signals up to the brain and say, there's danger, there's danger. And actually what is the cause here is just that there's damage to the nerve fiber, or the nerve per se. And this other pain is where you have a combination of all these things, or neuroplastic pain, we normally also call it. And this is where the funny things or conditions that doctors can't really find a cause for, and then we flag it as, or put it under an umbrella term, for instance, like fibromyalgia. Now, it's a condition that can have different symptoms in different people, but the long and the short is we know that it's basically no physical cause, but rather a central sensitized pain, which can be very difficult to handle because it's normally not something that we can control or treat properly with medication. It's just purely that we can't find the cause for it. Right, let's skip this slide just for a time's sake. Peter?
Not so long ago,
Yes.
many scientists believed that the brain did not change after childhood, that it was hardwired and fixed by the time we became adults. But recent advances in only the last decade now tell us that this is simply not true. The brain can and does change throughout our lives. It is adaptable, like plastic. Hence, neuroscientists call this neuroplasticity. How does neuroplasticity work? If you think of your brain as a dynamic, connected power grid, there are billions of pathways or roads lighting up every time you think, feel, or do something. Some of these roads are well-travelled. These are our habits, our established ways of thinking, feeling, and doing. Every time we think in a certain way, practice a particular task, or feel a specific emotion, we strengthen this road. It becomes easier for our brains to travel this pathway. Say we think about something differently, learn a new task, or choose a different emotion. We start carving out a new road. If we keep travelling that road, our brains begin to use this pathway more, and this new way of thinking, feeling, or doing becomes second nature. The old pathway gets used less and weakens. This process of rewiring your brain by forming new connections and weakening old ones is neuroplasticity in action. The good news is that we all have the ability to learn and change by rewiring our brains. If you have ever changed a bad habit or thought about something differently, you have carved a new pathway in your brain and experienced neuroplasticity firsthand. With repeated and directed attention towards your desired change, you can rewire your brain.
All right, so just to start concluding, last time we spoke about the fallen condition of the human, and the things that actually make us sick is our negative emotions, fear, guilt, and shame. And this is also, if we take it on a spiritual level, brings separation between us and our Creator. So fear, guilt, and shame always present with symptoms. We try and compensate for fear with idols. Our guilt normally makes us rebellious, and our shame will present itself in the form of pride. And the emotions that we normally have is unloving, sadness, conflict, impatience, unkindness, bitterness, and this self-indulgence, harshness, and unfaithfulness. And we actually open spiritual doors for all these diseases to enter our body, because these causes, let me put it this way, will present, which happens in our spirit will manifest in our body in some sort of a symptom. And if we want to change our fear, the treatment is love, and love comes in the form of trust, and then we will have love, joy, and peace. If we want our guilt, to treat our guilt, we've got to live in righteousness, in submission, and that will bring patience, kindness, and goodness. And if we, want to change or treat our shame, we've got to honor and live in humility, which will bring faithfulness, gentleness, and self-control. And maybe for those of us Christians, we will recognize these as the spirit of the fruit of the Spirit. And this is a simple little illustration of what happens in our soul and our spirit will manifest in our bodies, and how we can change these diseases or symptoms just by thinking different. So I think I'm going to stop here, Jasper, and maybe just conclude to say that, remember, before you go to a doctor with all these things, what doctors need to do is, number one, exclude life-threatening conditions. So we need to look out for, basically, if I can put it in three categories: life-threatening cancers, infections, and fractures. Most of the other stuff is not life-threatening to our bodies, okay? But our body will always try and warn us of possible life-threatening conditions. And we need to decide with our brain, is this danger to me or is it safety to me? Right. Medicine has got a place, right? If you break your leg, you will have to wear a cast for a few weeks. You might need crutches. Or if you have a fever, it would be a good idea to not just sponge yourself down, but maybe take a Panado to try and break the fever. But these are all treating symptoms. We shouldn't be dependent on them. And I come back to the question that I've asked last time as well. If your chronic condition, or if your chronic medication is working, why do you take it? If your blood pressure medication is working, why do you take it? Or if your antidepressant is working, why do you take it? Because it's purely treating a symptom. We as doctors feel good if our symptoms are under control, if your blood pressure comes down. But have we really treated the disease? Because the disease is still continuing in our body. We just control the symptoms. And if I can bring it back, my idea is to try and get us to think differently about health, to think differently about how or what we do with our bodies, and rather try and address the cause and see if the symptoms will change. Pain, for a simple reason, acute pain, like I said, if you burn your hand on a hot plate, you need to be able to react. But chronic pain is something different, completely different, because 9 out of 10 times we can't change the environment or the initial input. It happened. You had a broken leg, and now, or you had a surgery, and now you've got pain in the scar. And the question is this signal real? Is it really life-threatening? Do I need to react to it? Or can I change the way my brain interpret this signal and say, this is not danger to me, I can ignore the signal? Now, I'm oversimplifying things. Really, there's a lot more to this topic. I've been involved with this for the last 13 years of my life, and I'm still learning the whole story about it. But just to try and give a flip side of the coin, that there are other options available, that there are other things happening in our body, and maybe not the way we were taught to think about pain and diseases. Jasper, I think I'm going to stop here for the time being.